talking about lung cancer, but not the aspects of it that most of you are probably used to hearing. I'm going to focus on a lot of the patients I treat are women, and a lot of them have never smoked. Actually, more than half my patients have never smoked. And that's a disease, it's a population that people don't think about as getting lung cancer, so I wanted to go through that with you. All right, so first of all, just to remind all of you that lung cancer is the #1 cause of cancer death for women and for men. And so when you ask the majority of people in the United States what's the #1 cause of cancer death, they're all going to say, in women, they'll say breast cancer. That's not true. It's actually lung cancer, and that's why this is such an important disease to be learning about. And actually, it kills more than breast, colon, and prostate cancer combined. So this is really a significant health issue. Okay, so I can't talk about lung cancer and not mention smoking, because that is still the #1 cause of lung cancer. We estimate that about 80% of women who get lung cancer have a smoking history, a little bit more of the men. There are other causes, and there's a lot of research being done looking at that. So of course, secondhand smoke, radon exposure has also been connected with that, and then a lot of other pollutions. There's a lot of work on car pollution and trying to figure out people who live close to freeways, if they're at higher risk or not. These are difficult things to study, which has made it a big challenge, but we're working on those. Okay, so just to emphasize the smoking, this is the last one I have talking about that. You see here that the green represents cigarette consumption. These are the years. And it was in 1964 that we got the first release that cigarette smoking is harmful. There had been rumors about it before, but this was the first real statement that yes, cigarette smoking is harmful. It's linked to a lot of health issues, including lung cancer. And the gray line are men who have died of lung cancer. And you can see that there was a big drop for the men that sort of follows. There's a lag time, obviously, because it takes 10, 20 years, we don't know exactly, but there's a lag time between the smoking and developing the lung cancer. So you see here that there was a report, people stopped smoking, and then we see a decline in lung cancer deaths for men. If you look in yellow, though, that's the lung cancer deaths in women. And you can see it's lower than the lung cancer deaths in men, but what's a little harder to see is that we don't have that decline. If anything, women continue to smoke in the 60s and in the 70s, and those rates, while they've started to come down, we still are seeing an increase in lung cancer deaths in women. It's not as fast as it had been, but it has not yet really even plateaued, let alone start to decline. So this is still a big issue. Okay, now getting into some of the biological differences. We know that women with lung cancer live longer than men with lung cancer. And that's across stages, it's across treatments. This slide I show to kind of illustrate that because it looked at 20,000 older patients with lung cancer, men and women, and then looked at those, this was all early stage patients. So those, if they were younger, surgery would have normally been the treatment plan. So you look at the blue lines are women and men who had surgery, and you can see that for those who had surgery, the women in the solid line did better than the men who had surgery. If you look in yellow, those are people who were treated with chemotherapy and radiation, which is another way we treat early stage lung cancer. And here again, the women did a little bit better than the men. And then the gray are those who had no treatment at all. And even if you had no treatment, the women did better than the men. It wasn't as striking as with the surgery, but so there's something going on from a biological standpoint we haven't quite figured out. Okay. Moving more into more advanced stage disease, and I'm a medical oncologist, as Marcia said, so most of the time I'm meeting with patients who have metastatic lung cancer. I'm the chemotherapy doctor, and so my research is focused a lot in chemotherapy and differences there. So this is work we did looking at a very big clinical trial for patients who had advanced stage lung cancer. And what we did was we looked at the men versus the women who went on this trial, and there were about 1,200 patients total who went on this study. And you can see that if you looked at how likely the tumor was to shrink, unfortunately those numbers aren't great, but they're the same for men and women. And then if you looked at how many patients were alive at different time points, despite the fact that there was no difference in response, there were more women alive at 1 year and alive at 2 and 3 years than compared to the men. And that was statistically significant. Now these are all getting the same treatment, response rate was the same, so again highlighting that there's something about women who have lung cancer where they do better than the men, and we still haven't figured that out. This is highlighting the toxicity differences, and perhaps that's part of it. So if you look, for most of the symptoms that are signs from the chemotherapy, the nausea, vomiting, hair loss, nerve issues, almost all of those are higher for the women than for the men. The p-value there indicates the statistical significance, so anything less than 0.05 we would say is significant. So you can see pretty much everything on this is statistically significant. The only thing where men had more toxicity was in cardiac toxicity. So then we still wondering why we saw these results. So one theory is that maybe there are higher drug levels for women, and that's why we see more toxicity. Perhaps they're just having more treatment. Again, we haven't proven that. That's a theory. There are differences in the natural history, as I showed you on that earlier slide for the older patients with early stage disease that we still haven't figured out. Maybe there's some hormonal factors, and I'll talk about that a little bit more in my next slides. There are differences in certain things like how well women versus men repair any DNA damage, and chemotherapy is working through DNA damage, so that could be part of it. And then these undetermined factors. So what does this mean for now? It means that when we are designing trials, we need to make sure that we have equal numbers of men and women on the different arms of the study, because if you ended up with a trial where there were more women getting one particular treatment than men, and that trial showed that that one treatment looked better, people were doing better, you have to make sure that's not just because there were more women than the men. So we're careful to make sure that those studies are balanced now. Okay, so now what about these hormonal issues related to lung cancer? Marsha, as you know, it's one of her big part of her career is working with the Women's Health Initiative, and she's very kindly brought me in to do some of that work, which has been very, very interesting. And so this is a highlight of the Women's Health Initiative trial, and I'm sure most of you are familiar with this. So this was in postmenopausal women, and they were randomized. This was a very big trial. This part of it was over 16,000 patients. They were randomized to either get a combination of estrogen and progesterone in this part of the study, or to get a placebo. And what this trial showed the world was that that combination of those two drugs caused a lot of problems, actually. It wasn't helpful. It was potentially harmful for most women. And if you look here at this global index, that's sort of the overall harm versus benefit, and the fact that it's over 1 indicates that there was more harm than benefit. And you've seen a lot of this data. It's obviously made headlines, been very, very important information, and has changed a lot of how we think about giving hormone therapy to women postmenopausal. So we were able to then go in and look at lung cancer specifically in this group. And when you're looking at lung cancer, you're looking at, or with any disease, any cancer, you want to look at two aspects of it. One is the incidence, or how likely it is to develop, and the other is the mortality or the death rate. And usually those things would track, but not always. And so in this situation, what you're seeing here is that the number of women who were taking hormone therapy who developed lung cancer was this line here, and the women who developed lung cancer who were on the placebo is here. So it was not a big number, 96 versus 72. This number is not actually statistically different, so we can't say it's actually a difference, but that's what the numbers are, okay? But when we looked at the survival, so how many women who had the lung cancer, what was their survival with that, it was actually worse for the women taking the hormone than for the men. So even though the total numbers weren't that different, there were more cancer deaths from lung cancer for the women who were getting the hormone therapy than those who weren't. And these are the numbers here, 67 versus 39 deaths. So again, it's not huge numbers. This was 17,000 people. This isn't, we talked about it, it's a common cancer, but cancers aren't that common overall. And when we're talking about lung cancer, we look at the stage, which is, has it stayed just in the lung, has it spread to lymph nodes, has it gone elsewhere? And obviously when it's stayed in the lung, we can cure people. If it's spread elsewhere, we're trying to control the disease, but we can't cure. And if you look at the total numbers who had the more distant disease, so having spread more, it was higher in the group who were getting hormone therapy than the group getting the placebo. So half of these women, when they presented, it was already widespread, versus only just over a third of the women in the other group. We also found that when you look at the tumor under the microscope, it can look sort of well differentiated, meaning less aggressive, versus the more aggressive or poorly differentiated. And here again, there's a difference where more of the women who were on hormone therapy had these more aggressive looking tumors than those who were taking placebo. So perhaps the reason that we saw higher cancer deaths in this group was that women, when they got lung cancer, it was more likely to have already spread by the time it was discovered and to be more aggressive. More work needs to be done because these numbers are small, but we're not going to have other randomized trials looking at this particular patient population. So that's where it is. Okay. Now, the Women's Health Initiative wasn't just that trial. It's a very, very big series of trials that were all done looking at this issue of hormone therapy. And so another piece of it was the randomized trial with just estrogen. Now, this was for women who had already had a hysterectomy. So we know that you can't give estrogen alone to a woman who's postmenopausal and still has a uterus intact because of the high risk of getting cancer of the uterus. So this is for women who had already had a mastectomy, didn't have any history of breast cancer. And they were then randomized, and it was a slightly smaller group, but still quite large, to placebo or just to get estrogen. And here, the global index wasn't as striking, so there wasn't clearly any benefit, but there also wasn't as clearly harm as there was with the combined group. And when you look here at the patients who had lung cancer, especially non-small cell lung cancer, and the deaths, there wasn't any real difference. These hazard ratios, when a hazard ratio was 1, that means there's no difference between the groups. If it's above 1, then one's worse than the other. But none of these show any real significant difference. And so, unlike in the combined progesterone and estrogen trial, in the estrogen alone trial, there wasn't as clearly of a difference. So then we wonder, well, is it the progesterone? And there's still a lot of work being done there. We do have a lot of data linking in estrogen with lung cancer. We know that there are estrogen receptors in lung cancers. The progesterone data hasn't been as clear, so we don't have as good of a lab story to kind of follow along with this observation. So it's an area that's ongoing for research. Okay. So what about lung cancer in women? In summary, there are more never smokers with lung cancer who are women versus men, and I'll talk about that in the next slide. We have some understanding of biological differences, but really a lot more that needs to be done. Once diagnosed, women tend to do better than men, but we don't know why. And this is not necessarily true for the younger women. So when you look at lung cancer in general or in women, it tends to be disease of patients who are in their 50s, 60s, 70s, and less so for younger women. If you look just at the younger women, and the numbers are small, unfortunately they tend to have poor outcomes. And that fits in with the hormone theory that we were talking about. But again, very small numbers, so limited data. We're looking at hormonal therapy, so the anti-estrogen, anti-progesterone trials are being looked at in lung cancer. Menopausal hormone therapy is potentially harmful. And future research is still stratifying by sex, so we try to make sure there are equal numbers of women on the different arms and better understanding of the biology. Okay, so now I'm going to move into never smokers, making sure that Yuri has enough time. So the idea of lung cancer never smokers is harder to answer in this country because the cancer registries, the data that's collected about cancers in this country, doesn't actually have the smoking data in it. So you're not able to directly link in who smokes and who doesn't smoke, who gets lung cancer. So it makes it a harder question. And you think, well, that's ridiculous, but it is the way it is. And part of it is how that data is gathered. A lot of it you have to go back into the charts of the patients, and the smoking data isn't always as clearly identified in that, but we're trying to improve that. So it makes it difficult. So work that I've done with the Cancer Prevention Institute, California, and some investigators there, they have access to a lot of these cohorts. And cohort trials are when you have a group of people who don't necessarily have a disease, who enter baseline questionnaires and then are followed over a long period of time. And over time, people develop illnesses. And then you can look to see what's different about the groups getting this illness versus that illness compared to those who don't. So, and it also has smoking data and a lot of other lifestyle issues. So there's been a lot of work done with these cohorts. They've been fabulous. So the California Teacher Study is centered near here. And then some of these others you've probably heard about, the Nurses Health Study, Health Professionals Follow-Up Trial. These are very well known for those of us who do epidemiology work. Okay, so this was our data, collecting those cohorts and then looking at the people who got lung cancer. And as expected, the white bars are those who were still smoking. They have much higher rates of getting lung cancer. The former smokers, there's a big drop, but still higher than the blue bars who are the never smokers. All right, so that wasn't particularly enlightening to see that, but it reinforces what we know. But if you blow up the blue bars, the people who have never smoked, you see there are differences, and that there are higher rates of women with lung cancer who are never smokers than men with lung cancer who are never smokers. So links in with the sex differences. And looking at this further, so in the US, the incidence rate, so likelihood of getting lung cancer in non-smoking women, ages 40 to 79, is about 15 to 20 per 100,000 person years, which is higher than that for men. Almost 1/5 of lung cancer in the US in women is in never smokers, okay? And that's the same rates, that 15 to 20 per 100,000 is similar to cervical cancer or to thyroid cancer. And that's, again, that's just the never smoking women with lung cancer, so it's quite high. Okay, now if you look globally, about 15% of lung cancer in men is in never smokers, but over half of the lung cancer around the world in women is in never smokers. In parts of Asia, 60 to 80% of the women who get lung cancer have never smoked. And it's not all secondhand smoke, right? There's something else going on we haven't yet figured out. And never smokers with lung cancer, they do have a better survival than those who are continuing to smoke, likely because of other health issues, pneumonia risk, that kind of thing. Okay. So, and why does this matter? Well, now I'm moving back into treatment because, again, that's predominantly what I do, is treat lung cancer. And the patients who have lung cancer who are never smokers, we've been able to really understand their disease in a totally different level than in the last 5-10 years, where we can get to the molecular underpinnings of the disease, figure out what gene has changed that caused the cancer, and many times now we can go in and directly target that gene. So many of the genes that go wrong in lung cancer are what we call the tyrosine kinases, which are these molecules that sit on the surface of a cell, and when they get a signal, they tell proteins within the cell to turn on and change what's being made in the nucleus and lead to tumor growth and other problems like that. And if you turn them on all the time, that puts the cell into overdrive and that can lead to a cancer. So we've developed ways of turning those off. And a lot of them go in business end, turn off the business end, or they're antibodies that take away the signal from the environment. So there are a lot of different ways of going after that when you can figure out which gene, which of these proteins is involved. And one of these that's had a lot of press in lung cancer is the EGFR, epidermal growth factor receptor. And this is one of those on the cell surface, tyrosine kinases. And it turns out that this is involved in cell growth, proliferation, differentiation, and there are drugs that specifically target it. And as these drugs were being developed, people realized that in some lung cancer patients, these drugs had phenomenal responses. And they tended to be people who had never smoked, were women, this is the data from that. So women were more likely to respond, and those who had never smoked were much more likely to respond than others. So then investigators looked at those patients, looked at this particular gene, and found that they had very specific changes, mutations in the gene that was found only in these patients who had these dramatic responses and not in anybody else's lung cancer. It's not in the patient, it's just in the cancer. So something happened along the way, there was a change in the gene that led to cancer. And when someone has that kind of cancer, which we can now test for, they have great responses to the drugs. And again, this is highlighting it. So for women, about 40% of women who have lung cancer, higher if they're never smokers, have these gene mutations in this EGFR. And for non-smokers, it's about 1/3. And if you go to different parts of the world, if you look in Korea and never smoking women, it's like 70% have this particular gene mutation. And so what does that mean? You can get a really good response to these drugs. This is a trial looking at one of the drugs versus standard chemo. And in the patients that have the mutation, they had a much better response in green to the EGFR targeted drug than to chemo. But if you didn't have the gene, it didn't work very well at all. And so this has changed the way we think about treating lung cancer. And actually one of these drugs called Erlotinib was just approved yesterday by the FDA in this exact setting for patients where they have the mutation, they can get the drug first line and have these great responses. Okay, and that, I'm focused on that. I'm going to be ending now, but just to show you this big pie of all patients with lung cancer with adenocarcinoma, the EGFR is maybe 10, 15%. But we now can figure out what is the driving mutation in over half of our patients who have lung cancer. So this KRAS is more common. We still don't have the drugs yet, but we're getting closer. ALK, we have drugs now approved that we know work just in patients who have that gene change. And there's another one called ROS, and all of these, we're getting closer and closer to being able to, for every patient, say, all right, this is the gene mutation, this is the drug that's going to work and better treat our patients. Okay, so in summary, lung cancer is the leading cause of cancer death for men and women, more than breast, colon, and prostate cancer all combined. There are more never smokers with lung cancer who are women versus men. Menopausal hormone therapy might make lung cancer more aggressive. We still have more work to do there. EGFR targeted therapy has really changed our whole understanding of how we treat lung cancer. There are these driver mutations now that I said are over 50% of adeno, but it's really over 70% for the never smokers. We could figure out what is that gene. And research is really leading to rapid changes in treatment. So with that, I'll stop and let Yuri give his talk, since I think I went a couple minutes over.
It's a pleasure to be here. My emphasis as a gastroenterologist and not as an oncologist is in screening and prevention, so I'll tell you about that, and I won't really be talking about treatment. First, a little bit of an anatomy orientation here. The colon is the large bowel, or the large intestine. It's a long tube, about 5 feet long, part of the digestive system. Its role is to absorb water and salt from food. We don't need it to live, so patients who need to have a total removal of the colon can do fine, and they're hooked up in various different ways. The rectum is the last 6 inches of the digestive system, and one thing we'll talk a little bit about later is sigmoidoscopy. This is the sigmoid colon, so one of the exams to look at part of the bowel is sigmoidoscopy, and it stretches about this far in, whereas colonoscopy is the exam with a flexible tube that looks at the entire colon. Colorectal cancer, as you've heard, is the 3rd most common cancer in both men and women, and the 3rd leading cause of cancer-related death in men individually, women individually, but it's the 2nd when you combine both. And it's estimated that a large fraction of colorectal cancers, maybe half, can be prevented completely by screening. So we'll focus on this. To put the absolute risk in perspective, for men, there's about a 1 in 18 chance of developing colorectal cancer throughout one's lifetime. For women, the numbers are similar. So one of the first perceptions that I want to dispel is the sense that colorectal cancer is a problem among men. It's not. It's pretty much same risk in men and women. You'll see that the age at which this happens is a little different, but women live longer. So the cumulative risk throughout life is about the same. Now, looking at potential association with family history, about 3/4 of all cases of colorectal cancer don't happen in people who have relatives with colorectal cancer. And this is important when we talk about screening, because population-based screening applies to everybody, whether or not you have a relative with cancer. The risk is higher in people who've had cancer in the family, and about 1/4 of people present with such a history. There are some very high-risk syndromes that are not common that raise the risk of colorectal cancer tremendously. We don't know the cause of most colorectal cancers, but as with most cancers, this ultimately goes down to changes in the genetic material. Much of this may have to do with people's lifestyle, or frankly, just with being alive. We accumulate changes in our genetic material simply with aging. But there are several specific risk factors that epidemiological studies have linked with colorectal cancer, and so when we think about prevention, these things come up. They're not surprising in terms of the menu of things that you've heard about in terms of healthy living in general. Physical activity, if people are less active, it increases the risk. Obesity and overweight raises the risk of having cancer. It's also known that it raises the risk of having the pre-cancers that we screen for, and that I'll talk to you about in a moment. Smoking raises risk. Heavy alcohol use raises risk. And having type 2 diabetes raises risk, linking this back to overweight, because many times those go hand in hand. Now, current screening recommendations suggest that people who are age 50 and above and are considered at average risk should consider screening. And those guidelines really come from graphs like this, where you see that as people get older, the chance of developing colon cancer goes up. And it begins to take off here in the 40s and 50s. So one has to make a judgment in terms of public policy about when to start. This is where the number 50 comes from. But the other thing to realize is that people who have a family history, and this is at least one first-degree relative, so parent, sibling, child, who has had colorectal cancer, that increases the risk. And you can view this one of two ways. Either that at a given age, people have a higher risk, or that the entire curve seems to be shifted this way about 10 years. And this is where the number comes from for saying that people with a first-degree relative should start screening around age 40. So these things aren't completely made up, but you can see they're not perfect. We're not going to catch everybody. Often you see public campaigns by people who've had colorectal cancer younger, and they say we should be screening everybody younger. This is a public health question at what age one starts. This is where it comes from. Now, this is a very important concept. Colorectal cancer, in the majority of cases, passes through a precancerous stage that we could potentially identify. We can't see all precancers, but a lot of cancers come through polyps. The more obvious ones are like this. They stick up like mushrooms. The less obvious ones are flat, but we've gotten a lot better at finding flat lesions. So the idea is that with screening, we might be able to find not only early cancers that are much more curable, but also find precancers, remove them, and thereby actually prevent colon cancer. So to some extent, colorectal cancer screening is a little bit of a misnomer because depending on the technique you use, we're also screening for the precancers and hoping to provide prevention. Now this slide is very important in terms of the relative risk between men and women, and I'll walk you through it. This comes from a large study where colonoscopies were done on a large number of people, and the question that was asked is, how many people do I need to colonoscope in order to find something important, something that I care about? And this important thing that I care about is either an early cancer or an advanced adenoma. This is a precancer that's getting close to cancer, because there are other adenomas or other polyps that may or may not go on to cancer. I think they're important, but what's really important for sure is the advanced adenoma, when things going from adenoma, advanced adenoma, cancer. So what you can see here first is that in the red we have men, in the blue we have women. So for every age range, in the 40s, early 50s, later 50s, the 60s, you need to screen fewer men than the number of women to find one of these important lesions, meaning these things are more common in men for a given age. That's point number one. Point number two, the number of people you need to screen goes down the older we get, because we all are more likely to get these things the older we get. And so back to the slide that I showed you about starting around age 50, here 1 in 17 men who gets colonoscope will have one of these lesions, either cancer or advanced adenoma. 1 in 28 women will have that. What's the right number? What's the right answer? There's no absolute answer here. It's a judgment call. But I will point out that we can consider this the following way. Men in their 50s have about the same risk as women in their early 60s. So in the future, it may be that we will start to differentiate a little bit the current recommendations. Now, you can imagine that any statement that says start screening women later could be met with some resistance. You'd say, why? What's the problem here? You're discriminating. Well, that's if screening is all good, but there are potential downsides to this as well. So the point is, until now, we are managing everybody the same. We say everybody should get screened at age 50, but there can be some rationale for saying that men and women should be approached differently. Now, some people might flip it the other way and say, if we're screening women in their 50s at this level of risk, why not start with men in their 40s? And again, this is all a question of public health decisions and the potential benefit as well as the demand on the health system and expenditure. Now, what we know about polypectomy, or removal of polyps, comes from a variety of studies. This is one of the most important early research studies in the 90s, the data were reported, where patients were observed after the polyps were removed. And here they had high-quality colonoscopies, often twice, to make sure that the colon was completely cleared. There was no comparison of leaving the polyps in place because that was not considered ethical at this time. So the comparators are people who had not had their polyps taken out based on historical controls or the general cancer rate in the general population. And you can see that a follow-up of 7 or 8 years, the number of cancers that occurred in these patients who had polyps removed here was very low compared to various estimates of what would have been expected had the polyps been left in place. But again, we don't have a truly randomized comparison where the polyps were left in place. And from this came the initial estimates that one can reduce colorectal cancer by as much as maybe 90%. We now know that that's probably optimistic. Not everybody's getting the type of intensive colonoscopy that was done here. But still, the current estimates of 50% or more of potentially preventable colorectal cancer are probably accurate. So, preventing colorectal cancer. Some can be prevented with regular screening. Screening is defined as testing in people who don't have symptoms. So the idea is you take perfectly healthy people who may not even feel like they need to go to the doctor, and you offer them a test to either find cancer or another disease, and the idea is that you can find something early when you can still do something about it. And in colorectal cancer, as I mentioned before, the key thing here is the potential to find the precancers and prevent cancer in the first place, or to find an early stage tumor that is curable. That's the reason to screen, remove the polyps, and to find the cancer early. So 2 potential benefits. What are the types of tests? Some tests can find both polyps and colorectal cancer. Some primarily find cancer. You may have different sets of recommendations from different bodies making suggestions. Ultimately, a lot of this comes down to informed choice between the patient and whoever's advising them on what to do. And so I'll give you a brief outline of these various tests. First, there's flexible sigmoidoscopy. That's a scope exam that looks at the end portion of the colon. This has been used for screening longer than colonoscopy, the test that looks at the entire colon. A test that's not used very much anymore is an X-ray test called a barium enema. And something that's received a lot more attention recently is CT colonography, a test that looks at the entire colon that has some radiation associated with it. Its role is not yet clearly established. In the news recently, there's been a lot of discussion in the last few years about sigmoidoscopy and colonoscopy. And the way I would summarize it for you is as follows. We have excellent data from controlled trials that sigmoidoscopy decreases cancer rates, cancer deaths, and even the suggestion that it might decrease overall death, which is a very tall order for any randomized study to show. And that was actually a study, a couple of studies actually, 3 studies that looked at groups of people, randomized people to sigmoidoscopy or not. So this was not leaving known polyps in place, but it kind of functions that way because there's some people who never got looked at. And in that very rigorous design, sigmoidoscopy definitely works. Colonoscopy. We don't have such high quality data yet, but there's a lot of observational data, and one can draw the inference that colonoscopy should be as good as sigmoidoscopy in the left side of the colon, the part that the sigmoid reaches. And the argument has been, does colonoscopy do anything beyond the area that the sigmoidoscope reaches? And there were some papers in the news some years ago that said colonoscopy is not doing anything in the right side. I would say that the papers that came after that suggest that colonoscopy, especially if it's high quality colonoscopy with good attention to the prep, good attention to flat lesions, can decrease cancer incidence in the right side. So the summary now, the fair summary, and this is not because my specialty does colonoscopy, but I think the fair summary is that colonoscopy does have advantages over sigmoidoscopy. It's up to the policy people to debate whether the incremental benefit is worth the incremental cost and the risk. We've done some studies on that suggesting that if you can get reasonable protection on the right side, it is worth it. But this is something for you to discuss. Now, the reality is that sigmoidoscopy has become very rare in the United States. Its usage has gone like this, and colonoscopy has become much more common. But you should be aware that most guidelines still consider sigmoidoscopy a reasonable test, excellent benefit in the area that it reaches, but no benefit above that. Now, there are other tests that indirectly detect problems in the colon. And the first 2 are based on blood. The fecal occult blood test, the traditional test. The second one, a fancier occult blood test, the fecal immunochemical test. These need to be done more often. So if somebody wants a non-invasive program, they're willing to do this every year or 2. They're willing to accept that if the test is abnormal, then they go for the colonoscopy. These are reasonable options. I think the FIT is better. In my mind, there's not much of a reason to go with the older FOBT anymore. So if you're going to go for a non-invasive program, FIT is the way to go. It has decent detection capability for the advanced polyps, but it primarily detects cancer. It's wrong to say it's exclusively a cancer detection test. It's not. So one can still get some prevention from these tests. And in fact, the first solid set of evidence that this type of screening could decrease cancer in the first place came from the FOBT studies. So even those older tests were still detecting some polyps, and at colonoscopy they were removed, and then patients had some prevention. So when you discuss this with your physician, if you have a complete discussion, all of these will come out as options. The stool DNA test is under development. It doesn't really perform that much better than the FIT, and it's much more expensive. So its place in the armamentarium still needs to be defined. The current guidelines, as I mentioned before, recommend that at age 50, both men and women should begin regular screening. The intervals vary. For colonoscopy, if it's normal, we would ask patients to come back in 10 years. If they have polyps, we'll bring them back sooner because people who form polyps are more likely to form polyps again. So those patients are now in what we call surveillance, where we watch people more closely. Barium enema, if you're going to do that, it's every 5 years. CT colonography, still trying to work out the interval, but the current recommendation is 5 years. Sigmoidoscopy is not in this slide. The recommendation there is 5 years. And these other tests, the stool tests, are recommended every year with a stool ddNA still to be determined. So what can you do to prevent and beat colorectal cancer? First, the lifestyle things make sense, but I'll tell you from the start that in terms of absolute magnitude, the greatest impact is probably screening. So be active. Exercise makes a difference. Limit sedentary behavior. This will help in your overall health anyways. High fruit and vegetable diets, low fat, low red meat, include whole grains, and alcohol in moderation. All these things make sense. Get tested if you're 50 or older. If you do have a family history, discuss with your doctor the degree of the family history. For many people, this means starting at 40. In some cases, people live in families with very high risk, and you might need genetic testing, or you might need to start even earlier. There's a lot of room here for informed decision-making between you and your doctor about what you want to do, and discuss your history to see if there are other things that might increase your risk. I made the point before that of all that we can do, screening offers the best way to prevent cancer or to finding early, and finding it early offers the best chance at successful treatment. And the main point here in terms of screening asymptomatic people in the population is, again, that early cancer has no symptoms, but that's the time to find things. So don't wait for symptoms. Treatment is most effective when cancer is found early, and of course, the best thing is if we can prevent it altogether. So with that, I'll be happy to take any questions, and Heather, you may want to join me in case people have questions for you. Yes?
Do you recommend more often screening to women with a history of other cancers, such as breast cancer?
It depends. The brief answer is that for breast cancer, no. For most other cancers, no. There's one classic syndrome, Lynch syndrome, where endometrial cancer, uterine cancer, and colon cancer go together. And one of the things that we're trying to do now is tease out which women with uterine cancer might be in Lynch syndrome families. And the recommendations for Lynch syndrome are colonoscopy every 1 or 2 years, starting at age 25. So actually, one of the things that our pathology department is doing now is routinely testing all newly removed colorectal cancers, but also all newly removed uterine cancers. And they're doing research on all newly removed ovarian cancers, looking for the 2 to 3% of persons among those groups who might have Lynch syndrome. So it's a little bit of a longish answer. Routine breast cancer, no, but other things, maybe. Yes? Yeah, so that's a good question. So most cancers are closer to the rectum. About 2/3 are in the left colon, or what we call the sigmoid and descending colon. So if somebody's going to do, quote, just sigmoidoscopy, you are getting at the majority of the lesions. But the cancers on the right side are maybe 35, 40%. And actually what we've seen in terms of epidemiology recently is what some have called a, quote, shift to the right. More cancers on the right side of the colon. I don't think that there's any biological shift. I think that what's happened is that the screening to date has prevented more of the left-sided cancers. So in an unscreened population, more on the left, and the general population is getting pretty close to 50-50 because of screening. Yes?
How long will it be before the polyps turn into cancerous tissue?
So good question. There's indirect evidence for this. The number that people throw out is around 10 years. That's part of the original justification for the 10-year interval between colonoscopies. We've kind of backed into knowledge about the intervals now that people have been getting screened by studies looking at people going forward. So before we didn't know. Now we've had people who have had a colonoscopy, things are normal. The question is, what do you find at 5 years? What do you find at 10 years? If things are clean at time 0, 10 years later, small chance of finding anything. So we don't have a direct answer to your question, but about 10 years is what people say from a small polyp to an invasive cancer. The only warning is that in some of the genetic syndromes, that's a lot faster. So back to Lynch syndrome, the annual interval, we do have cases where we have a clean colonoscopy. Next year, the patient has a cancer, not a polyp, a cancer. And the question is whether it was a little polyp there we missed or whether the whole thing went through in a year. But an average risk, many years.
I have one more question.
Yes.
In the sDNA test, you are looking obviously for cellular DNA. So how do you distinguish the DNA that comes from the blood tissue versus the intestinal tissue?
So you're talking about the fecal DNA test.
Right, sDNA.
Yeah, so that's a great question, and the answer is you don't know where the abnormal DNA is coming from. Most of it is coming from from cells that are shed in the GI tract, but there's other stuff in there as well. And then one of the questions you might ask is, how do I know that this comes from the colon? So one of the questions that the company has had to answer over time is, abnormal stool DNA, colonoscopy normal, are you done? Or does this person have a stomach cancer or a pancreas cancer or something else that's shedding? And it's hard to know, but those things are rare, and we still don't know all the answers there. Yes?
Is the screening rate different for men and women?
Good question. I'm glad you raised that. So the main point of this symposium is to focus on women's health, but it depends what population you look at, and in general, women are better at prevention. So this gives me a chance to ask the women in the audience, if you have men you care about, get them in to get screened, because the men we screen often come in because the women in their life ask them to. So in some populations, the rate of women showing up for any type of screening is higher, yes. It depends on the studies, because in some studies, women are more reluctant to have the so-called invasive tests. Although if you have a woman colonoscopist, some women prefer that. So it's kind of a mixed bag, and overall, I would say that women are better about getting screened at all. Great, thank you.